Thank you, Vijita, for the kind introduction. So my topic for my today's presentation is on radiotherapy. So I have no financial disclosure. So just to give a brief introduction, what is all about radiotherapy, in particularly for the treatment of retinoblastoma. So we know radiotherapy comes in two forms. One is external beam radiation, and another is plaque brachytherapy. What I will be basically discussing or limiting my talk to plaque brachytherapy because that is one form of treatment what we usually do for retinoblastoma. Before the era of intravenous chemotherapy, EBRT was the treatment of choice. But now I think over the last 3 decades, I think systemic intravenous chemotherapy and the newer forms of intra-arterial and intravitreal chemotherapy have taken over. And EBRT remains a very small subset of treatment, particularly for patients with orbital or extraocular extension of retinoblastoma. So plaque brachytherapy basically can be used either as a primary form of treatment if the tumor is very small, solitary, unifocal, or sometimes it can be used as an adjuvant treatment, particularly if you have used the primary form of treatment such as intravenous chemotherapy, intra-arterial chemotherapy, and then you see a small recurrence or a solid tumor recurrence, then you can use plaque brachytherapy. Basically, what do you mean by plaque brachytherapy? Brachytherapy means delivering the radiation close to the target area, that is the tumor from where it originates, and it delivers a very small, highly focused radiation particular to the tumor with minimal or very small amount of kind of scattering of the radiation to the adjacent surrounding structures with selective dose distribution. So indications, particularly retinoblastoma, radioactive plaques, what I be discussing basically are the secondary plaques or adjuvant treatment following local treatment of your primary IVC or intra-arterial chemotherapy, or sometimes even in the primary form it can be used for group B retinoblastoma, where if it is a unilateral unifocal tumor. The eligibility or indication, particularly when you can use plaque brachytherapy when the tumor lateral basal diameter is less than 14 to 16 millimeter in size, or the thickness is less than 6 millimeter if you are using a ruthenium plaque, or if you have a facility for using iodine plaque, then it can be extended to over 10 millimeters in thickness. In terms of indication, basically we use plaque brachytherapy in our setting, particularly for recurrent and residual tumors after failure of our systemic and focal therapies. Indication, as I told, it can be unilateral solitary tumors, tumors less than 16 millimeter in base, less than 6 millimeter in thickness, and tumors which are kind of located anterior to the equator or near the ora serrata, and sometimes very rarely if the tumor is in the parapapillary region, if you have a facility to use notch plaques, they can also be used. Contraindications, that is very important where not to use plaque, particularly in anterior segment involvement. Typically, if an indication is a clear-cut indication for enucleation, you have anterior segment seeding, ciliary body involvement, preferably better to go with enucleation. Juxtapapillary, I think it all depends upon whether you have a facility to use notch plaques or not. And larger tumors, massive tumor recurrence with vitreous seeding, subretinal seeding, I think it is advisable better to go ahead with other forms of treatment than using radiation. Types of radiotherapy, as I told, plaque or external beam radiation can be used. In our setting, we use ruthenium 106 plaque, what we have currently in our facility. It comes in two forms, 16 millimeters which is round plaque and 20 millimeters which is notch plaque, preferable for small to medium sized localized tumors in anterior or kind of mid peripheral equator. So this is the article what we have recently published, and it is published in the Brachytherapy, which is an official journal of American Society of Brachytherapy. So I'll be just discussing few highlights of this article. So what it was a retrospective study which was conducted at our Tertiary Eye Care Institute from all the medical records reviewed from 2002 to 2022, with where we have used ruthenium plaque either as a primary or as an adjuvant treatment following failure after systemic intravenous chemotherapy. The dose rate what we use is 0.6 to 1.5 gray per hour, with prescription dose ranging from as low as 40 grays to as high as 46 grays, which was variable over the treatment time of less than or from 3 minimum day of 3 to maximum 7 days. Whenever we calculate the dose at which the tumor height should be determined, it always calculates 1 millimeter extra for the scleral thickness and 1 millimeter for the safety margin. And lateral tumor margins always take 2 millimeters into consideration. So particularly, just to give an example, if the tumor is 10 millimeter in size, you always go for 14 millimeter or 16 millimeter plaque, so that you have an ideal 2 millimeter margin on either side of the lateral boundaries of the tumor. And follow-up was again at 3 monthly interval. So I will skip this. So in our study population, we had 44 eyes from 42 patients with kind of bilaterality seen 60% of cases, and 3 patients had a family history signifying germline mutation. The median age at presentation was 12 years, with most common symptom, as you can see in India, we see white reflex or leukocoria as the presenting complaint. The median symptom duration, again, it is 2 months. So most of the patients, whenever the parents notice white reflex, they usually come to the primary practitioner or they are referred to the tertiary care center to rule out retinoblastoma. And in terms of grouping, the majority of tumors were in group D or group C or group D, determining that basically all these patients present at a very late stage in our resource setting, and early screening and early treatment is advisable. In terms of treatment, what we usually do, particularly for group C to group E stages, what we primarily usually give 6 cycles of intravenous chemotherapy with adjuvant focal therapy, depending upon the small tumors seen in an area where we can able to do laser or cryotherapy. In terms of recurrence, after giving 6 cycles of intravenous chemotherapy, close to half of the patients had a solid tumor recurrence, one third had a kind of solid tumor residue within the area of primary treatment, and 12% had subretinal seeds and 7% had new solid tumors at some other location. So the most common type of regression in which the recurrence or the residual disease was seen, that was in type 3. As we all know, this is the type of regression which is more common to cause any kind of future recurrence or residual in the area where it was primarily treated with intravenous chemotherapy. In terms of plaque, the maximum basal diameter mean was around 6 millimeters, ranging from less than 3 to as high as 12 millimeters. But tumor height, as I told you, because we are using ruthenium, so the maximum height what we could have in our setting was 6 millimeters height. The tumor location, again 75% were all kind of posterior to the equator, and the type of plaque what we use was 2/3 we use round plaque, and in 1/3 we use notch plaque, which is having a larger basal diameter of 20 millimeters. Additional treatment along with the radiation plaque brachytherapy, what we use was transpupillary thermotherapy and cryotherapy to the small surrounding tumors, or in cases where there was a vitreous seeding, we kind of complemented with intravitreal topotecan injection. In terms of regression, I think close to 50% of cases we saw persistent tumor regression following the plaque brachytherapy. However, in 8 cases, we could see there was a recurrence, again originating from the area where the plaque was there. I think that might be enabled whether the localization of the tumor or the placement of the plaque might be not be kind of exactly accurate, and that's where I think our understanding at how to use plaque, particularly in case of a child, particularly retinoblastoma, I think it is very, very important. And recurrence elsewhere, I think that is always kind of scenario, particularly in cases where you see recurrence following primary intravenous or intraarterial chemotherapy. In terms of outcome, the cumulative incidence for enucleation at 2 years was 25%, with going as high as 58% at 4 years. So I think that's what it is the message what I want to give. If you do a plaque brachytherapy, the enucleation incidence rate was around 50% at 2 years, but then it increases as high as 84%, which showing an increasing trend over the time. So I think the recurrence following plaque brachytherapy, it is always advisable to go with secondary enucleation rather than going for other focal forms of treatment or repeating your intravenous chemotherapy. In terms of significance, what is the risk factors for enucleation? So any tumor which has undergone type 2 regression following plaque brachytherapy, it has 7.3 times higher risk of enucleation, and if associated with vitreous seeds during your plaque brachytherapy, again it has a higher risk of enucleation. So I think these two factors you need to be taken into consideration before we subject any patients for plaque brachytherapy. Again, non-significant factors like location, thickness, and type of plaque were not significant. In terms of complication, it is very important. I think whenever we use plaque brachytherapy in early post-op, if there is a neovascularization or there is a vitreous hemorrhage, I think what is advisable that you should not use plaque brachytherapy. But in late radiation-related retinopathy, usually happens close to around 6 months to 12 months down the line, and what you should be looking, particularly if the tumor is at the posterior pole or near the optic disc, optic neuropathy, radiation retinopathy, and cataract are something what you need to look for. So final outcome in our study, out of 100%, close to 1/4 of patients had a final visual acuity of more than 20/200, with only 10% of them achieving 20/60, which is kind of very good. What is the take-home message from our study? The crucial 7 months post-treatment is most important, because most of the recurrences, even after plaque brachytherapy, happens in that critical time window period. So you need to be very kind of diligent in noting this and making sure that you don't miss out any small solid tumors or recurrence, especially in the area where the plaque was done, or also not in the other areas. So the few case scenarios, this is a kind of 3-year-old child where you can see macular location of retinoblastoma. Following 6 cycles of intravenous chemotherapy, beautifully regressed with type 3 regression. Again, after 8 months, you see nicely regression at the posterior pole, but you can see small solid tumor recurrence seen in the inferior nasal quadrant. After plaque brachytherapy, it kind of showed beautiful response in terms of flat chorioretinal scar and chorioretinal atrophy. Another case, where you can see 6 cycles of intravenous chemotherapy, beautifully responded, but 15 months down the line you could see there was a recurrence both at the nasal quadrant as well as there was anterior chamber seeding. And for the nasal recurrence, what we gave plaque brachytherapy ruthenium, and you can see then again flat chorioretinal scar. For anterior chamber seeding, we injected intracameral chemotherapy, that is topotecan. Last case, again after 6 cycles of intravenous chemotherapy, beautifully regressed, but then there was a recurrence for which plaque brachytherapy was done. This was a juxtapapillary tumor, but unfortunately there was again recurrence and we couldn't salvage the globe. The patient ultimately underwent enucleation. So to conclude, I would say ruthenium plaque brachytherapy is a valuable salvage treatment for retinoblastoma. It achieves good tumor control and globe salvage, particularly in selected cases. If your selection is good, you determine the lateral basal diameter and thickness of the tumor and the location of the tumor and your localization of the tumor during plaque placement. It is very, very important. If you take care of all this, I think you will achieve very good response to your plaque brachytherapy. And close monitoring is always advisable, particularly to look for recurrences not only in the area of the plaque but also other area, and look for early as well as post-op radiation-related complications. Thank you.
Thanks, Dr. Vishal, for summing up the how and when of